We move to next session. For the next session, I invite Dr. Ravi Singhvi, Dr. Priyank Modi, Dr. Nikunj Kotecha, Dr. Kamlesh Thakkar, Dr. Vipul Kapoor, and Dr. Tejas Patel, Tejasvi Patel, as respected moderators and chairperson. I request them to invite the speakers and introduce speakers, please. Chairpersons, please introduce the speakers.
Good evening, everyone. Am I audible?
Yes.
Yes, Dr. Kamlesh, please go ahead and introduce all the three speakers, and then we can have the case and then go to the presentation directly.
Thank you, Kamal, for the such a nice event and very nice lectures. So I will invite first our speaker, who is Dr. B.C. Kamath. He is going to say something about the stent selection in a given case. And the case is 50 years old doctor with a diabetes, having unstable angina, who is planned for a PTCA stenting to a tortuous, angulated, long segment 90% mid LCX stenosis, which is having a large OM arising across it. The stent parameters that will help in managing this patient best would be Dr. B.C. Kamath is going to say about the stent design and its parameters like stir thickness, trackability, radial stent, which is more important. So, do we have Dr. B.C. Kamath?
Yeah, good evening.
Good evening,
am
sir.
I audible? Yeah, thank you.
Yes, sir. Yes, sir.
Thank you. Go ahead. Next will be Rajneesh after me. Yeah.
And then we'll have
Yes,
Dr.
sir.
Rajneesh and the next slide. Then we'll have Dr. Nikhil Parchure. Can we have the case, please?
Yeah.
The scenario, please.
Okay.
Yeah. The case is already shared by the chair. Dr. Kamath, next slide. Something like this. Next slide.
Correct. Okay.
Next slide. And we can have Dr. Kamath. Over to you.
Yeah. Thank you, all the chairperson. Thank you, Dr. Kamal. It's been you're taken a hurricane effort to whichever the latest concern. You've taken a lot of efforts to really conduct this conference, and Jignesh is there. My dear friend Jignesh, how are you? And Dr. Kamlesh Thakkar, and of course, Dr. Kamal Sharma is there. I'm sure my whole job is made easy by my dear colleague, my moderator, when he gave me said that when you have such a tortuous vessel, diabetic gentleman, long vessel with the bifurcation, then naturally you will definitely need a very important or very superior stent. So if you see the patients wherein you having such problem with the more diffuse and small patients with diabetic patients have more what do you call diffuse vessels, smaller vessels, thrombogenic disease, and also they have endothelial dysfunction and impaired platelet dysfunctions, and these are all things makes we need to have a very really good stent to show that the rates are comparable to all the stents. That's why this patient being diabetic, a doctor, a bifurcation, and a long vessel makes everything important here. So ideal stent, naturally, being a doctor, I have said, look for US FDA approval. There's no doubt about it. We are not going to talk about other stents unless the why US, we're not running after the US, but US FDA has made such a stringent things to be included in the parameters. They have got huge data to unless the patient stent comes on the platform, unless it is great deliverability, trackability, conformity, and especially there are some stents have got a diabetic role like Onyx, or you can say the Freedom, or even these stents have a major diabetic workup. We need a stent which is a longer, a reasonable drug elution period. I'm not say very long, reasonable, with stent of better over expansion capacity without fracturing, and better radial strength, which enables stent have a not have a luminal loss and no foreshortening and elastic recoil. So if you look at the platform and the delivery, I would say naturally the polymer and drug will not, because all the polymers have become, all the drugs have been equally good now. So what will important would be the polymer and the flexibility and the thrombogenicity and the radial strength and foreshortening, because here is a diabetic guy who has got a real tortuous vessel. You saw the angio there. So we have three great strengths. We have Zymes, and we have Synergy, and we have, of course, the great Onyx one from Medtronic. The biggest change which has occurred in Zymes has been the delivery systems and balloons. But the one thing which has rapidly evolved with Onyx is that not only delivery system, the polymer has changed, and the structural single coil structure has made it a very, very important stent in the market now, because it will take a huge development of other people to really compete with. Synergy has to come up something, or Alpine has to come up something to really come near, because this century if you see the strut cross section here, the Zymes and the Resolute and the Synergy, many of the square or even the Orsiro or Bifreedom as a square thing, whereas the rounded structure makes it less traumatic to the vessel wall, and the thickness should be something between 75 to 85, because too small like 60 Orsiro is not good for large vessels, and too thick like by Freedom we had 112, which is little, because it's okay that it does not have polymer. That's another different story. Here we want a good polymer or a great drug which is good enough, and also most important, the thickness and the structure of the stent is very important. So we have three workhorse stents here which are competing here: the Synergy, the Expedition, or the Alpine, on the Resolute Onyx. Of course, Ultimaster is not behind, and by Freedom or Orsiro are not behind, because Orsiro has some characters which are thin strut, which makes it more trackable. But there is a bench strength when you say trackability between Onyx and Orsiro has been also great, that Onyx and Orsiro are very, very comparable. Very few instances we may say the Orsiro can cross better, but compared to Synergy and Expedition, Onyx is superbly trackable because of the structural single coil structure, and also the rounded structure of the cross section of the stent. And this makes a huge difference in deliverability. Here we want a very deliverable stent, good drug, and a great side branch access because of the great OM coming there. That's why we have a moderately thin strut, that is 80 microns of Onyx, or 75 to 80 microns of Synergy would be comparable here. And of course, 61 microns is not comparably, because we are larger vessel, 3.2 vessel here. So if you look at one of the trials telling that the ISAR stereo, which said that strut thickness too bigger will not be good enough because it causes luminal loss and laminar flow will be lost. So 61 to 80 microns is great. That's why we have, when you assess stent choices, we have driver platform of Onyx, and Liberty was slotted tube, and multi-link vision is about as a time immemorial. Zymes has been playing that. So real competitor, I would say, Synergy and Onyx, and Onyx will have a greater role here because of the trackability and a single wire technology. It makes it very, very sinusoidal, makes it very trackable, and most important, gives a great conformity of the vessel, makes it a lovely stent here. So I will bet my money on Onyx here because of the enhanced radio opaque. Also, that another thing is important. If you look at in this slide, that how visible is this, because of platinum iridium, which is the alloy which is used, unlike the other metal alloys, where is a platinum iridium makes it visible. At the same time, it is not a nickel, which sometimes causes more endothelial dysfunction, as we've seen in the Zymes platform, other platforms. So thinner struts, reasonable struts, good opacity, and stent platform, which makes it fantastic. If you look at the cross section of when you do an IVUS or even we do the OCT, we look at the side branch, wherein side branch accessibility has been phenomenal for the Onyx, because we do so many left mains with the Onyx. I did 2 left mains today and 1 left main yesterday with the Onyx, with a greater approach, and it was so smooth for me to get into the side vessel, and do the job like kissing balloon or the crush or DK crush, and you could see a small momentum in how the stent conforms here, and because of the single coil structure, which makes it beautifully adherent to the, and also it has great radial strength. Radial strength is comparable between them. 4.2 of Stent versus 4.1 of Onyx makes it also greatly having a good what do you call the radial strength. And there's always a little because the strut structure is peak to peak makes it lesser fracture, unlike peak to value of synergy, which is also becomes a little hindrance here. So in this, my align the crowns are peak to peak and makes it more conformable and more. And then the foreshortening is also come down. So this all makes the foreshortening comes down. Why, my dear friends? Because the peak to peak does not allow it to fracture and foreshorten. And the sizes like 3 mm can go to 4.2, 3.5 can go to 5 mm, and 4 can go to 6 mm, makes it a phenomenally important stent for left main and other bifurcations. So I would put my money on Onyx to do it here, the great job here. And of course, Synergy as my backup and Orsuro as a backup here, because they're also great stents with great platforms. So, and these are the many. So looking at the patient history, he's a diabetic having small vessels, diffuse disease, tortuous anatomy, and a big side branch, and a diabetic gentleman. I would, as I already declared you, that my first would be Onyx and of course the second would be Synergy or Orsuro. Thank you, Chairman. Thank you, gentlemen.
Thank you, sir, for such a nice lecture about the stent design in treating this patient. Now I will invite Dr. Rajneesh Kapoor from Delhi. Dr. Rajneesh Kapoor doesn't need any introduction. He is a very well-known cardiologist of our country. So he's going to say about the drug platform, because today we have availability of very nice delivery system like GuideZilla, GuideLiner, and very nice catheters. And so he's going to say about the drug platform and the polymer, whether it's a biodegradable polymer for this given case. Over to you, sir.
Thank you. It's really a privilege, and it's quite. Am I audible?
Yes, sir.
Yeah. So it's quite visible that how much effort everybody has put in, and special congrats to Dr. Kamal Sharma, who has done a lot of hard work in preparing for this meeting, and the enthusiasm is quite visible amongst all speakers and all attendees. So although for our nation, it's Gujarat coming to Delhi, Gujarat is managing everything, but here Delhi coming to Gujarat, little opposite. Okay, so given this,
sorry to interrupt,
sir, please. Yes, sir. Yes, sir.
Yeah. So given this special circumstance and the patient point of view for which we are discussing, that which stent we should choose based on the drug platform, polymer or the drug. My job is more of theoretical, mainly because this is a really extensive theory which I'm going to discuss, that how drugs are coated and the polymers and durable versus biodegradable polymers and no polymer stents. So we have wide array of stents available with us. And if we have to choose based on these things, then how should we proceed? So this is evolution of PCI. We know we are in a drug-eluting stent era. And once we talk of that, mainly now we are here. We are talking, we have stents with a biodegradable polymer, which contains the drug, and drug is slowly released into the system. And then there are stents where there is a no polymer, but still drug is adsorbed onto the stent surface. And then we also have stents. We had a bioabsorbable vascular scaffold first generation, and we all know that somewhere there were lapses, and that didn't continue because of some complications of late stent thrombosis. But still now we are almost there with the second generation bioabsorbable vascular scaffold. We all know we have been using cautiously, but I think data is further piling up, and the limitations which were there in the first generation, to quite an extent, those have been obviated with the second generation. So three components of a drug-eluting stent: drug, polymer, and a stent platform. The key components of drug-eluting stent is the drug, and we all know sirolimus, everolimus, zotarolimus, biolimus, paclitaxel. We all have various stent platforms available which contain different drugs. Dosage, how is it coated? This is important. Another important stuff is polymer. So what is a polymer? Polymer actually is a substance which is a carrier for that drug. So now initially there were durable polymers, but then there were problems faced with the durable polymers, some inflammation, and then late stent issues were faced. And then almost all stent platforms, major stent platforms have shifted from a durable polymer to a biodegradable polymer. Composition of polymer is important, and even now we have drug-eluting stents with no polymer and they are available. Stent designs are important. My previous speaker has talked about that. I won't be going into that detail. The platform of the stent is again very important. Diabetic versus non-diabetic. This is a typical diabetic patient. So once we deploy a stent because of a polymer, some inflammation happens, and then there is a healing cycle. So that takes time. There are stents where a healing happens in few days in non-diabetic, but it's kind of prolonged in diabetic patients. Not going into that detail also, it's too theoretical. Coating polymer drug carriers in drug-eluting stents. The non-biodegradable or permanent polymers, the era is gone. So we are now into the era of biodegradable polymers. The second generation, so we have various polymers, the fluoropolymer, Endeavor has phosphoryl choline. These are all biodegradable polymers. PLA, PGA, and PLGA. So these are the biodegradable polymers. And then we have stents with no polymer. Yukon from Translumina, and then from Concept Medical US. So and a nanoporous hydroxyapatite. This is how the coating is done in non-polymer. Basically, it is coated onto the surface of the stent without any attached polymer. Latest generation drug-eluting stents, as I mentioned, mostly we are dealing with biodegradable polymers. All the major stents are actually with this. The attractive combinations of controlled drug elution in parallel with biodegradable polymers, which then converts into inert monomers. After completion of biodegradation, that drug-eluting stent practically becomes a bare metal stent. So the late complications are all avoided by virtue of that. Stents completely free of polymer after some time, and completely biodegradable magnesium and polymeric stents are there. Drug-eluting stents with biodegradable polymer, they have anti-restenotic benefits because we mentioned they are kind of eluting drug for quite some time, and then they after that to obviate the late stent complications, they get converted into bare metal stents. So these are the advantages. The data is very clear. Once it compared the biodegradable polymers with durable polymers, all results were in favor of less complications with stents with biodegradable polymer. These are almost the same things being talked about. And then also came an era. Now there is now a debate which happens whether the coating should only be on the abdominal side or it should be the circumferential coating. We have stents available now which only have a abdominal coating. We know Synergy, we know Abluminous. So these are the stents with abdominal coating biodegradable polymer. So it's a unidirectional drug delivery only towards the vessel wall and better in tissue penetration of the drug and more homogeneous. So this is what is being claimed. Non-polymeric drug-eluting stents also there is a data that it doesn't lead to any inflammation. So there's an improved healing with these kind of stents, improvement to the integrity of stent surface, and possibility of a shorter duration of DAPT in high bleeding risk groups. This is the advantage of non-polymeric drug-eluting stents. And this is what I was mentioning, a polymer-free and a durable polymer. The results were clearly in favor of the biodegradable polymer. So this is another stent where there is more innovative thing happening, abluminous stent. One, I mentioned it has a abluminal polymer which contains the drug. So it's a one-sided release into the vessel wall. Also, additionally, there's a fusion coating. The balloon on which the stent is mounted, the tips of that balloon. Now we know once we have a stent and a balloon, so there are some small fraction of a balloon which overhangs the stent on both sides. And we also know because of this balloon creating a trauma beyond the edges of a stent, the edge restenosis is fairly common. So what they have done a fusion coating where they also coated that balloon with a drug. So it's a drug-coated balloon and a drug-eluting stent combination. This is an innovative thing which they have done, and the results are also good with this stent. We are now fairly using this stent in large numbers. And once now we come to the comparison of all the stents available, it shows this diagram actually shows whether it's a full circumferential coating versus a abluminal coating, the strut thickness, and specifically the abluminous. So, and the polymer coating. So last line is polymer coating, circumferential 7 to 8 micron, 6 micron, 10 micron. So abluminal, circumferential, abluminal. So now based on this, if we have to pick and choose the stent for our patient based on the drug platforms and the polymer, I think from the word go, it should be a biodegradable polymer, good drug, and good strut thickness. And circumferential versus abluminal, we don't have a concrete data that which is better. This is on theory, it looks that abluminal is better, but there is no consolidated data on based on that. So resolute onyx, Zymes, or abluminous. And on third or fourth category, I'll also keep synergy. So these are the stents which we can actually think of using in this typical patient based on the drug and the polymer coatings. So a key takeaway message for an ideal stent, it should be a limeless drug elution for 60 to 90 days, followed by complete absence of drug release. This is also very important. The pharmacokinetics of drug release should be that it should be giving a good cover for 2-3 months, but then no release after that. A very thin surface of biodegradable or a durable polymer. I'm not counting durable, only a biodegradable polymer coating, a very thin surface. That stent is a preferred stent. Stimulation of early re-endothelization. And we have data now with the Onyx. We have data with BioFreedom that one antiplatelet can be taken off in a month or 3 months, respectively, with these stents. So if somebody is going for non-cardiac surgery, these are the better stents. A very low profile stent delivery system, high flexibility, conformability due to a hybrid open cell design, thinner struts, minimal late loss, a thrombus resistant luminal surface, a minimal duration of DAPT, and low stent thrombosis or ISR rates. So fitting into these last slide, I think the stents which I named, either Onyx or Zymes or to some extent Synergy and Abluminous, because of some innovative thing which they have done, I think these are the stents which we look at can give the best outcomes in our patients. Thank you very much.
Thank you, sir, for such a informative lecture about the drug platform and polymer. Now I invite Dr. Nikhil Pachure from Mumbai. He is going to say about new generation abdominal drug elution with a semi-absorbable platform that is being approved DES for such kind of patients, which we are discussing. Over to you, sir.
Yeah, very good evening, all of my colleagues. I'm going to make a case today for a new generation abluminal elution with semi-absorbable platform, and that's the only approved DES for such patients. I'm going to address the chairpersons and the moderators as my lords, and I'm going to be very precise, very robust in my presentation. I'm going to stick only to the evidence, and I'm going to bring in two expert witnesses to support my argument. One of them is going to be an international expert, my colleague, Roxana Mehran, and the other expert witness will be our very own Dr. Kamal Sharma, because both of them were involved heavily in determining the outcome for the stents which I'm going to make the case for. I'm here neither to make any lecture or nor to give you any stories. I'm here to produce and bring in only evidence to make my case. So my lords, what is the issue here? The issue here is about a diabetic patient who has come to the hospital with unstable angina and has been found to have tortuous, angulated, long diffuse lesion involving a side branch. In other words, here is a gentleman who is a doctor and who has been shown to have a complex lesion involving one of the coronary arteries. So the question here, my lords, is why do we need a dedicated DES for a diabetic patient? How is this stent different? And does it have any superior outcomes? And I'm going to stick only with this stent, and I'm going to present my case to support that this is the only stent which is suitable for this patient. When we look at this patient who is diabetic, which is a very frequent comorbidity found in our patients, and if you look at a very high volume, single center registry, all PCIs between January 2009 and 2014, what was the prevalence of diabetes? Almost 50% of all our cases, when we divide them into non-diabetic and diabetic, which proves that diabetes is very frequently found comorbidity in our patients coming to the cath lab. And indeed, our patient here is diabetic. So what is the problem with diabetes? Well, there's an increased risk of cardiovascular events and death associated with these patients. When we look at relative risk of CHD mortality, CVD mortality, and total mortality, it becomes very clear that if we take diabetes patient here alone, these mortalities are up to at least twice as compared to patients who are not diabetic. And this is very clear, and that is why we need to be very precise in dealing with these patients who are type 2 diabetic. Type 2 diabetic patients have more complex coronary lesions with increased necrotic core volume, increased inflammatory infiltrate, and increased calcification, as is shown in this study, where there are more macrophages, there are more T lymphocytes and HLA-derived DR. This is what makes these patients highly complex in terms of outcomes, where you have, my lords, already seen that the risk of deaths is at least twice as compared to non-diabetics. Therefore, we should take these patients, and this patient in particular, very seriously, my lords. Why? Because diabetes mellitus causes delayed vessel healing due to slow endothelialization and increased inflammatory response, leading to acute, subacute, or late and very late stent thrombosis, my lords, and a focal or edge restenosis, as has been talked about by the previous presenters. This is a very important slide, my lords, which clearly shows that the drug very commonly nowadays employed in stents is everolimus. And when we compare that with previous generation paclitaxis eluting stents, then it becomes very clear that as far as non-diabetics are concerned, everolimus has an advantage over paclitaxel in terms of target lesion failure. But when we look at the diabetic patients, there is no advantage, or the advantage which was there for non-diabetics has been lost in diabetic patients with the same target lesion failure as in both. And the same is true in diabetic patients, but the failure of target lesion is higher with everolimus eluting stents. So my lord, this is more serious as well when we look at the diabetic patient. And remember, our patient here is diabetic with long lesion, tortuous, angulated, involving a side branch as well. So in general, my lord, the outcome data for target lesion failure in diabetics is very high as compared to non-diabetics, both in terms of events, in patient-oriented composite events as well. That diabetes specifically puts our patient at a very high risk of adverse outcomes. Remember, my lords, I'm going to stick only to robust evidence to make my case. So how do we mitigate these risks, specifically pertaining to our patient here? Well, we already know now that the strut thickness is very important. And our stent, which we're going to employ in this patient, has to be thin strut, which elicits less angiographic and clinical restenosis, as has been informed to us by previous presenter, that our polymer has to be biodegradable, number one. Number two, the drug distribution has to be abluminal only as compared to conformal. And polymer degradation time has to be shorter as well, my lords. We also know that the type of anti-proliferative agent is important as well, where I'm going to make a case for sirolimus here, my lords. As you have seen, that the everolimus loses its advantage when it comes to diabetics. And nobody has spoken so far about stent balloon. And I'm going to make a case for stent balloon to be coated with drug as well, because our previous presenter clearly demonstrated that the edge is highly open for restenosis, my lords. You have seen this slide before, which clearly demonstrates that our stent called abluminous has only abluminal coating, number one. Number two, it's actually very thin, and abluminal only less than 5 microns, my lords. So that is why this stent is superior to all other stents which are at the moment employed for all other patients. This is what is very important, my lords, here in this slide. I'm not going to talk about this abluminal, but this is very important, that in between the stents struts, the balloon itself is drug coated. And at the edge as well, where the balloon extends beyond the edges of the stent, that part of the balloon is also drug coated, so that this drug is actually delivered to the vessel wall when we fully deploy the stent. And we'll see, my lords, that this all what I have just said translates into advantage in clinical practice in terms of outcomes for our patient. And how does that happen? How am I going to make that case that this really translates into practice? Is by all these studies, my lord, on which the most important study here is Enable Registry, where more than 2,500 patients were employed. And that's where our own Dr. Kamal Sharma comes in. He has clearly published real world data of more than 2 years for these patients, my lord, which clearly evaluated the safety of abluminous stents. Primary endpoint was major adverse cardiac events, and secondary endpoint was stent thrombosis. And there you go, my lords, the MACE, death, target MI were so low throughout in these patients who were diabetics, which were comparable to non-diabetics. Remember, we have shown in this that our patients' outcome data of adverse events actually is very comparable to non-diabetic patients, my lord. And that is a huge leap forward for our patients. So in conclusion, my lord, compared to non-diabetic patients, studies show inferior outcomes in diabetic patients undergoing PCI. And innovative stent technology targeting the specific needs of our patients with diffuse disease is needed to adequately address the target lesion failure in diabetic patients. The abluminous disc, with its unique coating technology on abdominal surface of the stent, as well as the balloon delivery system, is a very valuable option for diabetic patients. And more ongoing studies will show that. My lords, I hope that I have made a very robust case for the use of abluminal stent specifically for our patient, because he's diabetic, has long diffuse lesion, and I have shown in outcome data that this is the only stent which actually achieves of reducing the risk of major adverse cardiac events and target lesion failure for such patients. Thank you very much.
Thank you, Dr. Nikhil, for such a hot presentation. It was like hearing a debate in a Supreme Court by one seasoned lawyer. Thank you very much. Now the forum is open for the discussion. My co-colleagues, Dr. Vipul, Dr. Tejas, Dr. Ravi, Dr. Priyank.
Hello. Can I go ahead, sir?
Yeah,
Yes,
please.
Hello.
Yes, Priyank.
Yes, please.
Yeah,
Please,
audible.
Priyank.
Yeah. Just to summarize, BC Kalmat sir was in favor of Onyx, and the other were in favor of albuminous from Envision. Now, we very well agree that the technology what they promote is better. Two important points which no one discussed was, in today's era when we have such good delivery methods, usually it is never difficult to prepare the bed well. And when you prepare the bed well, most of the stents track down. Now, one basic difference which I have found with Onyx or the Onyx Synergy on one side and Indian stents on the other is when you track a long stent down and when you deflate the balloon, it is very difficult to bring the balloon out. And that is where Onyx has a difference. Like a 40 millimeter balloon, when you deflate after deploying the stent, you can easily pull the balloon out without the catheter being sucked in, which is an important aspect here because you are going to circ and you do not want to damage the ostium. And sir, Nikhil sir, if you are very pro, then why albuminous has not applied for FDA approval? And the drug also, the discussion on the drug was, you discussed everolimus versus Texels, and then it is a class effect in diabetic, whether it is sirolimus or everolimus, both would be not superior to Texans. It's not that they are inferior, but they are not superior. Why Texels or Plexitexel stents were thrown out and we have limus stents is because they were found to be superior, but in diabetics they were not that superior. But then that's a class effect when you consider whether it is everolimus or sirolimus. So sir, your points on that.
Yes, thank you very much for those important issues you have raised. First of all, FDA approval. I have not shown you in the lack of time that there is a very ongoing study called Dedicate, which is being masterminded from Milan. As soon as that data is out, everything is ready to be applied to FDA. Our own Dr. Kamal Sharma has shown, and I have seen their presentation in the past, that in diabetes with long diffuse lesion, outcomes with a repeat angiography in 6 months' time, and not one or two, significant number of patients who are presenting like this. Second question you have raised about the drug, which I agree with you, that probably the drug elution with sirolimus and everolimus are a class effect. But definitely, we have gone beyond the era of paclitaxel or taxol drugs, which are not as good as today's everolimus, zotarolimus, or sirolimus. Sirolimus actually came as the first, but it has stood the scrutiny of time in terms of outcomes, and that's why it has come back again, sirolimus, as compared to zotarolimus or everolimus. But I agree with you that probably the class is the same. Yes.
Thank you. Sir, I use both to the maximum because, anyways, thank you.
Congratulations, Dr. Kamal sir, for organizing such a grand academic feast once again for all of us. And I thank you. I thank all the speakers who presented their case very well. One question I had in mind that the patient was a doctor with a tortuous large segment tortuous circumflex, which is a large OM. So the point which was probably missed by that with the large OM may need a stent selection, which we have a large cell size. So if the cell size is big, then probably if you need to intervene into that side branch, a large OM. So again, I think Onyx would be scoring on that ground. What do you say, sir?
To me, question?
Yeah, I would like to, because
I can answer that. That's okay.
Yeah.
Because, I can answer that. Yes.
Because the previous two speakers were right, little bit in favor of Onyx already. So maybe they are taken into account that factor. So I think I would like to put it to you, sir.
Onyx is a very good stent, brilliant stent, and has been proposed as one of the stents for easy access to the side branch. Having said that, there are some parameters in terms of patients' lesion morphology, which determines whether when you stent the side across the side branch, whether that side branch is going to be pinched or not. I have not seen any more criteria given in that, and I did not have time to look at the angiogram properly, but it doesn't look like that side branch stenting across with any new stents nowadays is going to be a problem in terms of pinching of that side branch. Although I agree with you that Onyx is one of the better stents in terms of side branch access. Yes.
Thank you very much, all the three speakers. You did a wonderful job. Thank you, Dr. Nikhil, for mentioning me more than once for the publication that we did. And I think I was the only one who probably was not the investigator in that trial. I was just the one who drafted that manuscript. You all guys did actually more of Abluminous than probably I might have done for that registry. Of course, I do use it very often. That's a very well published and well accepted data now that we have. The whole idea was not to pitch one stent against the other, but was to discuss about the various aspects of the stents that are often overlooked. You know, people end up choosing one stent for the sake of one or the other reason, but there are more than one reason that you all three beautifully highlighted, that it's not just the drug, it's not just the deliverability, it's not just the platform, it's not just the polymer, it's not just the side branch access, strut thickness, cell design. There's so many parameters that an interventional cardiologist should learn and understand before he chooses and becomes an implanter. He should know what he's implanting. So that was very well brought out by all the three speakers. Wonderful session, all the chairpersons. Thank you very much. Any closing comments, Chair? And then we can close the session. Chairpersons, moderators?
So I think we have discussed everything, but we missed about the BRS, which I was going to ask for this case. So if anybody wants to put a comment, Dr. B.C. Kamath, sir, what is your take on for a BRS in a given case? As the patient is a doctor, he may ask for the BRS, our Indian BRS nowadays.
I having burned once my fingers, not me myself, I would always be skeptical. I've used only 2 BRS previously, and I realized when a lot of big shots who were getting their BRS done in Delhi coming back to Ahmedabad and getting the stent thrombosis, you also know, Kamlesh, that. And then I realized it's a playing with fire. I will wait for more evidences to come. So till then, I think I'm still going to wait around till the BRS actually gets you good data. And that's why we get good data.
Hi.
That's true.
Dr. Kalmat here. Hi,
Yes.
Kamal.
Yes.
And Kamlesh. And I thank you for that. All my colleague Nikhil and even Dr. Arora came back saying that ultimately the Onyx will going to play a lot of role in all these patients because there's such a huge data. And thanks, Nikhil, for proving my point. So because the side branch and diabetic, I don't think you have any competition when you look at all over the data, all the world. Of course, but he's a great man. He's like a criminal lawyer who can defend anybody and get them out of the Nikhil is like a criminal lawyer. Thank you so much.